Just give me a minute. I'm going to make sure the thing is recording. Yeah, the thing is recording. Okay, good afternoon, everyone. Welcome to our MYOSIG Vitreoretina Zoom webinar. My name is Tan, CK Tan. I'm from Hospital Temerloh. I will be your moderator for today. Before I introduce to our speakers, so I have few housekeeping announcement need to make. So please mute your audio connection upon login, and then there will be a pool questions before the talk, and then the Q&A session will be reserved till the very end of the talk. And then you guys are encouraged to join the pool question and answer them. So let me introduce our speaker today. Our first speaker, Dr. Mohan. Dr. Mohan is currently working in his own private center in Asia Eye Specialist Center located in Kuantan, Pahang. He graduated as an ophthalmologist from University Malaya. He serviced several hospitals, including Temerloh, Perak, and then he joined the Vitreoretina subspecialty training at 2017 to 2019. He's got his retina fellowship in Australia. He performed numerous cataract surgery and vitreoretina surgery and published in the international journal as well, and also international conferences. Our second speaker, Dr. Teh Wee Min. He is actually my senior from USM. He graduated as an ophthalmologist from USM. He served Hospital Kuala Pilah before joining the Vitreoretina subspecialty. He got his fellowship, Vitreoretina fellowship from Changgung Memorial Hospital, Taiwan. Dr. Teh, besides his experience in operation, he also published in many international journals and book chapter writing as well. So without further ado, I'm going to introduce these two topics today. Vitreoretina topic today is very, very important and common to us as a ophthalmologist, practicing ophthalmologist, general ophthalmologist, or maybe medical officer in the eye department. The first topic will be regarding diabetic retinopathy, and then the second topic will be cataract surgery in post-vitrectomized eye. So the first topic, the title is A Guide Walk Through the Dark, Predicting the Unpredictable Diabetic Vitrectomy Outcome. And then the second topic by Dr. Teh will be cataract surgery after vitrectomy surgery, pros and pitfalls. So without further ado, I will invite our first speaker, Dr. Mohan, to present his talk. I will stop screen share. Yes, welcome, Dr. Mohan.
Yep. Just give me a second to upload the screen. Okay, right. Thank you, CK, for an extensive introduction for all of us. Very honored to be invited today, and the talk today, I termed it a guided walk through the dark, predicting the unpredictable diabetic vitrectomy outcome. And now this is not a topic that we find anywhere written. This is something that I came up with based on my experience. The times I had difficulties talking to my patients and telling them what might be or what might not be because of what I perceive as a lack of local data about how we can counsel the patients about this surgery. So very, very frequently, the kind of picture that I painted in the eyes of patients was it's almost what we term as endgame. You've reached a stage where you need diabetic vitrectomy, and we counsel you, and the patient think, okay, this is one last chance, it's all or nothing. My chances are, very frequently I hear patients say, doctor tells me it's 50-50. Well, the truth is it's not 50-50, but what are the numbers, right? And I think this talk, I tried to, because of these questions that were in my head, I started to look around for a few researchers, a few papers, and so that I can compile my own data to have an idea of what the actual numbers are, what we tell the patients, what their chances are, and so it better gives us a better understanding and helps us to counsel the patients. So as we all know, the current global pandemic, everyone knows what it is. So the other global pandemic, which is equally important, is diabetes mellitus. And there are 285 million people worldwide who are affected by this disease, and about 1/3 of this have some form of diabetic retinopathy. Right? And we know this is definitely the tip of the iceberg because there are a lot of people who are walking undiagnosed worldwide. Right? So the prevalence of this disease of microvascular complications was 75% in diabetics, while 29% of diabetics suffered from macrovascular complications. And among those, the patients who had diabetic ocular complications, 27.2% suffered from cataract, followed by non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and advanced diabetic retinopathy was only 5.3%. Well, the numbers may seem small, but because most of us here work in tertiary centers or referral centers, you see a huge number of patients who come in with advanced diabetic eye disease. The rest of the stages of diabetic retinopathy can be managed as an outpatient, can be managed in clinic kesehatan and so on, right? And we know that 1.7% of diabetics are actually legally blind, which equates to more than 5 million people worldwide, right? So as something to just recap knowledge that we all have known for quite a while, the common indications for diabetic vitrectomies, the common ones are unresolving vitreous hemorrhage. Some people use 3 months, some people say 1 month, but basically if your vitreous hemorrhage doesn't resolve, then you need to have surgery done. Tractional retinal detachment involving the macula. The third one, combined tractional retinal detachment and rhegmatogenous retinal detachment, pre-macular hemorrhage, and diabetic macular edema in selected cases. So once we have these indications and we tell the patient, look, that they need to go through surgery, that's when the questions will arise in the patient's head. Most of the time they will wonder why I need the surgery, right? So we can tell them the indications, we can tell them that this is needed. Okay, so what happens if I don't operate on it? Will it go worse? What is the success rate of the surgery? People outside tell me that it's 50-50, right? Am I likely to have a successful surgery even if it's 50-50 in their eyes, right? How many surgeries would I require? What about my other eye? So these are the kinds of questions that we need to answer, but do we have enough data to answer these patients' questions? Frequently, I find myself in the past best guessing the answer. And best guessing the answer is never the best answer because we don't have real numbers for it, right? So what we do when we best guess is we frequently what do you call it? We try to dampen patients' expectations, and when you dampen patients' expectations, the future looks pretty bleak. So I believe Pushpa is here with us in the group, and so this is one of the studies that I've looked up on, and Pushpa and Dr. Better had published a paper on vitrectomy in advanced diabetic eye disease, a Seremban experience. And this was published in 2017, and it's a good study because it gave us a good set of data to kind of to know what kind of outcomes they would be achieved if we did a diabetic vitrectomy. So they did a retrospective cohort studies of 177 consecutive vitrectomies in 168 patients with advanced diabetic eye disease. And when they follow up, this is a retrospective study, so the follow-up, what they found was post-vitrectomy, 91.5% had improved or unchanged visual acuity. Anatomic success was achieved in 97.7% of eyes, and 15 eyes or 9% worsened by at least 0.3 logMAR units. And improvements of at least 0.3 logMAR units was seen in 74.7%. Great numbers. This completely threw me off. It's like, it's not 50-50, is it? It's not 50-50 anymore. We're looking at 90%, right? So what are the kind of complications you can get? Vitreous hemorrhage, they documented 21%. Retinal detachment occurred in 3% of eyes. Rubiosis iridis occurred in 3% of eyes. And they even had predictors of poor post-operative vision. If you had poor vision prior to operation, if you had macular detachment and you had preoperative rubiosis iridis, you were more likely to have poor outcome. I think this was a good starting point for me in trying to get this information, and this prompted me to carry out a study together with Dr. Widat and my other colleagues in Ipoh. This study is still unpublished, but this data that we've got more or less mirrored what Dr. Pushpa and Dr. Battle had published in their Seremban experience. So we did a retrospective cohort analysis of cases operated in HRPB Ipoh between 1st January 2017 and 31st December 2018. So it was 184 eyes of diabetics, but we chose a cohort group of patients below the age of 50. And they underwent diabetic vitrectomy, followed up for 6 months, at least 6 months follow-up, where we documented the visual acuity, intraocular pressure, and anatomical attachment success. This was our result. More or less, if you look at the arrow, post-operative visual acuity had improved significantly, and we even found there was post-operative improvement in visual acuity in those that were injected with anti-VEGF. Right? So our results show that 88.3% of eyes operated on had stable or better visual acuity at 6 months post-operation. 21.7% of the eyes worsened. 5 or 2.7% of the eyes had NPL vision at 6 months. And all the eyes that had NPL vision after surgery had a preoperative visual acuity of count finger or worse. I think at this stage, we are starting to see a certain pattern, right? So 4.9% of the cases required repeat surgery. 2.7% of those eyes were reoperated on for retinal redetachment. 4 were operated for non-resolving post-operative vitreous hemorrhage, and post-surgical anatomical and retinal attachment success rate was 97.3% at 6 months. So in Malaysia, that was the numbers we were getting. Were we getting the same thing overseas? So in 2016, one of the papers that I also had looked up on, this was published in Saudi Arabia by Abu Najma et al. To investigate the outcomes of pars plana vitrectomy for chronic diabetic traction macular detachment, where they retrospectively analyzed 96 eyes that underwent PPV, and they analyzed the retinal reattachment rate, final vision, and prognostic factors for poor visual outcome. In their paper, they put up an image, one of the success cases that they had. So if you see preoperatively how there was very broad fibrovascular membrane forming over the optic disc and bridging the macular region, and you see after surgery you have a very much in an advanced diabetic eye disease, this would be considered a pristine eye, right? So it looks very beautiful after surgery. So what they found was they had 90.6% of their patients had retina and macula reattached after 1 vitrectomy. At final examination, 84 eyes or 87.5% had stable or better vision. 3% had NPL vision. And those predictive factors, so if you look here at the bottom group of statements, those aged above 50, those with preoperative vision of less than 20 or 400, ischemic macula, were significantly associated with a final vision of worse than 20 or 400. They went a little further by analyzing the preoperative variables and to kind of extrapolate whether these preoperative variables had any effect on the outcomes of the vitrectomy. So what they found as well was that the type of diabetes, duration of diabetes, existence of prior panretinal photocoagulation, use of preoperative intravitreal bevacizumab or iris neovascularization, lens status, presence of vitreous hemorrhage, presence of thick fibrovascular tissue, duration of retinal detachment, all that were not significantly associated with the final visual outcome. So After looking at those 3 studies, we start to wonder if the numbers are too good to be true. It's not 50-50 anymore that we're looking at. We're looking at 85% and above retinal, stable or better vision rate. So it made me think, what were the rates of surgical success in the past, per se, or what could be the cause of the shift in success rates seen in diabetic vitrectomy. It was very hard to find research papers done on diabetic vitrectomy in the past which had immediate post-op follow-up. Most of the follow-ups that were done there were for long-term, but basically the numbers were as you see on the screen. So one of the first paper, Blankenship et al. In 1972 and 73 did a 10-year follow-up of 72 cases who did diabetic vitrectomy for complications of PDR, and of course it was at 10 years, 42% of patients had maintained a 660 or better vision. In Thompson et al. In 1986, did this retrospective study of 1,007 eyes with complications of PDR that underwent diabetic vitrectomy. They found that 79% of patients with vitreous hemorrhage had VA of visual acuity of 5/200 or better after the surgery. 64% of eyes with tractional retinal detachment had visual acuity of 5/200 or better. 56% of eyes with RRD had visual acuity of 5/200 or better, and 81% of eyes with progressive FVP, fibrovascular proliferation, had visual acuity of 5/200 or better. A simple chart here, Abbott et al., Abu Najma Gupta, and our study that we did here in Ipoh showed that stable visual acuity back in 1981 was around 71%. We mostly averaged 87 to 88%. Anatomical attachment rate 67% in 1981. The more recent ones are above 90%. Of course, if you look at Gupta et al., there's one outlier in the stable visual acuity or improved visual acuity at 39.4%, but that was because Gupta et al. Used good vision, used 612 as their marker. So they had 39.4% of patients with 612 or better vision. So why are we seeing these rates of improvements now compared to the past? So a lot of it is definitely got to do with the kind of technology that we have right now. So higher cut rate vitrectomy machines, we now have cut rates of 7,500 to 10,000 to 12,500 cut rates. So what this does is that this reduces lower cut rates. What it does is it cuts and it pulls, so it causes traction on the retina, doesn't allow you to get as close to the retina. And when we have higher cut rate vitrectomy machines, we're able to get closer to the retina, more maneuvering allowed close to the retina as well, and there's less traction. The thing that the speed does is that it liquefies the vitreous instead of cutting it. Smaller gauge vitrectomy cutters and instrument allow us to also deal with fibrovascular membranes easier because of the size, the ability to move under the fibrovascular membrane with smaller gauge vitrectomy cutters, less trauma to the eye, less inflammation because of the small wounds. Better illumination definitely helps. Better viewing systems from the microscopes to even the lenses that we use for viewing the posterior segment. The ready availability of staining materials for visualization of hyaloid, epiretinal membranes, and vitreous schices, which means we can see those structures that are abnormal, which are actually clear structures, which you find it hard to see with your naked eye. So having these staining materials aid us in performing the surgery, especially so in removing the posterior hyaloid of the posterior pole. And finally, the use of anti-VEGF, anti-VEGF agents prior to diabetic vitrectomy has shifted the paradigm of surgical diabetic vitrectomy outcomes. Although we saw that in Abu Najma et al. That the use of bevacizumab did not affect the results of their diabetic vitrectomy, but there was a huge meta-analysis done by Yinzhu Zhao et al., who meta-analyzed 14 RCTs involving 613 patients who received anti-VEGF prior to diabetic vitrectomy. And the analysis had shown better outcomes in terms of hemostatic control perioperatively and early post-operatively, shorter duration of surgery, less iatrogenic retinal breaks, less frequency of using silicone oil, and better best corrected post-operative visual acuity. So I'm quite convinced that at some point that the anti-VEGF does aid and does help surgery perioperatively and does help in terms of patients' final visual outcome. So as we head with all those numbers that I have given, I think it's only fair that I summarize everything as in how we are going to guide the patient through this moment of darkness where they think that they've only got a 50% chance or a 30% chance to kind of go through the surgery, right? So indications and success rates of vitrectomy had expanded over the last 2 decades, contributed in large parts by the improvement in technology and pharmacologic agents related to the surgery. So this could be, like as I mentioned, from the vitrectomy cutters to the viewing system and also to the use of anti-VEGF. Effective patient counseling for the operation is essential to garner patient trust and confidence in undergoing the procedure. Right? If you don't have the patient's trust and you don't have to, and patients are not confident about going through surgery, it will be very difficult to get a successful surgery done. Similarly, with good clinical data, clinicians are able to better advise their patients about the surgical outcomes confidently. So what are the clinical data that we're looking at? So we can now safely tell patients that diabetic vitrectomy anatomical reattachment rates are more or less above 90%. We also know that about 85% or more patients who undergo diabetic vitrectomy will have similar or better vision after surgery. So less than 5% of patients will have to undergo repeat surgery for the similar problem unless they were injected with silicone oil. The risk of going completely blind after surgery is less than 5%. And the group of patients at risk of having poor vision after surgery can be predicted by the following factors. So as we've seen in the earlier slides, there are a certain number of factors which we know kind of relates to poor visual outcome. So presence of rubeosis iridis prior to surgery, as we can see in the image here, is one of the factors that can lead to poor visual surgical outcome. Preoperative vision of worse than 660, from my perspective, from the study that me and my team had done, we found that count finger and worse is a predictor of poor visual and surgical outcome. Advanced age, the older the patients are, the slower the recovery and the poorer the visual outcome. So I was always pretty concerned about, whether the duration of diabetes, type of diabetes mellitus, how much we've done laser PRPs before we've done the surgery. So a lot of the studies show that these do not affect the final surgical outcome, right? Although we know that prior laser PRPs does assist and aid the surgeon in trying to perform the surgery. Right, so that will be the end of the talk, and I think the most important thing here of everything I say is very hard to remember the numbers, but the last 2 slides were the most important things. So when you talk to the patients who are going through surgery, I think you have favorable numbers. If they have the indications for surgery, I think they should be referred to vitreoretinal surgeons, and if they want to know about their risks, you can use these few numbers, the 85%, 5% NPL rate, those predictors of poor visual outcome and what their chances are. Right.
Okay, thank you, Dr. Mohan. I think diabetic retinopathy patient in our clinic actually has a huge load to our workforce in our eye clinic. And then we as ophthalmologists or the ophthalmology department also see a rise in the diabetic retinopathy came in the younger generation. So, so definitely this slide will help us to counsel and then the patient, and then when is a good timing to refer to Vitreoretina such facility. So I will reserve all the questions and the comment after our second speaker. So don't waste time. We invite Dr. Teh. So I asked Dr. Mohan to share the screen. I will invite Dr. Teh to present his talk, the pros and pitfalls in the cataract surgery after post-vitrectomized eye. Right, I'll give the floor to Dr. Teh.
Right. Thank you very much, CK. Very good afternoon to everyone. Thank you to the special mention to the Malaysian Society of Ophthalmology, the Young Ophthalmologists Group, for organizing this webinar and for the kind invite. So without wasting much time, we will go into the slides. Just want to have a quick survey of how many of you actually have experience dealing with cataracts in vitrectomized eye patients. So if you have, if you see a pop-up screen right now in front of you, just click yes or no, and we'll see the results in a short while. All right. So let's move on. All right. So as we all know, I think cataract surgery in post-vitrectomized eye is becoming a more common scenario in your clinics. The reason being that vitrectomy has become the mainstay of treatment for various retinal conditions, and cataract formation after vitrectomy is a well-known complications, with up to 80% of these patients developing cataracts, significant cataracts requiring surgery within 2 years after the vitrectomy. So among the risk factors for the development and progression of cataracts are older age group, the degree of pre-existing pre-op nuclear sclerosis, intraoperative trauma like lens touch, of course diabetes itself is a risk factor, and the use of tamponates like silicone oil. All right, all of you may be familiar with cataract surgery, and as a surgeon, the main aim for surgery is that we have good outcomes, safe surgery with good outcomes, right? So it's quite straightforward in that sense. But when it comes to vitrectomized eye, the cataract surgery may be a bit more complicated compared to that. You see the goalpost is actually shrinking, so your margin for error is actually much less. There are more chances of complications happening. And you may have to negotiate various obstacles or tricky maneuvers, or even the pre-existing traumatized eye when you deal with cataracts in this type of patients. So you have to move your way around, but eventually if you follow certain steps and do them right, I think you will still be able to score the goal, which is to give better outcomes, visual outcomes, and perform safe surgery. So I've already mentioned why cataracts develop after vitrectomy, and one of them is actually lens touch due to the instrumentations during surgery, the tamponade agents that we use, and also the pathophysiology is postulated to be, I mean, there's definitely disruption in the lens metabolism, and also because of free radical damage to the lens proteins. So what could possibly go wrong in vitrectomized eye? When you are thinking about performing cataract surgery? Well, there are many things that can actually go wrong. So you always have to remember that a vitrectomized eye is basically an abnormal or a traumatized eye. Yeah. These eyes harbor a sequelae of previous surgeries, and so there's definitely inflammation going on. They have comorbid conditions like diabetes, glaucoma, corneal compromise, or even lens instability. And nuclear brunescence is already quite common, pre-existing prior to the vitrectomy. And one factor, in the vitrectomized eye, you will see that there's actually lack of support from the absence of vitreous gel, making surgery a bit more trickier than usual. So this is just a simple animation to show what can go wrong. Yeah, the instruments can hit the posterior aspect of the lens, and sometimes may even lead to posterior capsular rupture. You can have tamponade agents like your gas or oil disrupting the lens metabolism, particularly at the posterior aspect. Of course, one of the reasons why we do vitrectomy is because of trauma, with retinal detachments and RD or vitreous hemorrhage post-trauma. So they might be associated injuries elsewhere in the anterior segment, which may also hamper your view during surgery. Poor pupillary dilatation is also one common problem, not just because of the vitrectomy itself, but because of pre-existing medical conditions like diabetes. The scleral rigidity will decrease in patients like this. You will notice that there will be increased iris lens diaphragm retropulsion in these patients. The zonules are definitely weaker with a lack of support from the vitreous gel, or maybe due to trauma from trauma and also from the surgery itself. Like I mentioned, a posterior capsule may be compromised, or sometimes there might be even a thick fibrotic plaque located at the posterior capsule, especially in silicone oil eyes. So some pearls that I can share with you when you do, and when you decide, or when we are considering whether to do cataract surgery for these patients. Number one is, of course, history. Always get a good history from the patients. Review the past medical records. If you need to, you may have to ask the Vitreoretina Center, which you referred to, for details regarding the surgery, what happened during surgery, and also what could have possibly gone wrong during surgery. One of the things that you need to ask, number one, of course, is the indications for the surgery, be it trauma or from diabetes or from other indications like rheumatologic retinal detachment. Very important is actually what was done during surgery. Was a scleral buckle implanted? What tamponade agent was used? Sometimes you need to dig a bit deeper to actually try to find out whether there was any iatrogenic lens touch and all that. But I mean, there's no reason to hide this part of the history, right? So I mean, if you ask the primary surgeon who did the vitrectomy, I think they should be quite happy to provide you with these details. And of course, the intra-op findings of the vitrectomy, that will give you a very good idea of what is the visual prognosis like after the cataract surgery. Yeah, if you, if the surgeon told you that the optic disc is pale, the macula is scarred, the vessels are sclerosed, then you know that visual acuity may not improve as much as you expected it to. I've already alluded to this, the complications during vitrectomy like lens touch. All right. So after history, you have to get a good, you have to do a proper examination of the eye. Look for any presence of conjunctival episcleral scarring. Not so important or not so relevant in if you're doing phacoemulsification, but this might be important if you are doing ECC, for example, or if you're going to implant a single piece rigid lens. If you have the facilities, try to get an endothelial cell count, because this might otherwise give you a surprise, or the cornea can decompensate after surgery because of low cell counts. Do take note the anterior chamber depth, because that will actually give you an indication, of whether you're going to struggle during surgery. The presence of emulsified silicone oil bubbles in the AC might also give you an idea, that there might be silicone oil emulsification already posteriorly. So whether you are going to combine cataract and also silicone oil removal. I will show you some videos later on to show you that it is possible for a general ophthalmologist to do phaco with oil removal from the anterior segment. First, presence of any iris or phacodonesis, which will indicate a compromised zonules. That is, of course, something that you look for during your examination, and the pupillary dilatation. If the view permits, you should have a detailed examination of the retina to give you an idea of what is the condition like, and also again to prognosticate the eye following cataract surgery. So these are just some slit lamp photos of the types of cataracts that you may encounter. Yeah, this is actually a cataract found in a very young patient with silicone oil in the eye. You can see the abnormal formation just behind the lens. And if you take a close look at the picture on the right, you can actually see that there's actually a clear zone here. Yeah, And this is usually around 10 o'clock or even 2 o'clock. So this is actually indication of a lens touch with possible breach of the posterior capsule in this patient during the vitrectomy. So be very, very careful in these patients, yeah? All right. So yeah, this is also another commonly encountered scenario where you don't even get to see the fundus or even the pupil or even the lens for that matter because of emulsified silicone oils. So this is also another photo showing a fully filled anterior chamber. Emulsified silicone oil fully filling the anterior chamber. All right. I'd like to share a video of the same patients just now, and this was the intra-op surgery. This is courtesy of Dr. Willie from Alostar. Hi, Willie. All right, so you can actually see that the oil, the emulsified oil, readily comes out when you do some gentle irrigation, and with the help of vision blue staining and also your viscoelastic, you will still be able to perform the cataract surgery without much problem usually. You'll notice that emulsified oil will keep coming through, will keep coming forward through the zonules usually. But yeah, once you have your viscoelastic in, it should be able to give you a good temporary, give you some time for you to perform all your necessary maneuvers. All right, so here with the aid of the vision blue, you can actually visualize the anterior capsule very well, and you can do your CCC safely. Yeah, so shouldn't be an issue here. Right. This is another example of post-vitrectomized eye, young patient with silicone oil posteriorly. So you can see there are 2 ports already inserted for removal of silicone oil. But look at the lens, it's really white and intumescent. So yeah, this was actually a surgery done by me in my early days. So yeah, the same thing, vision blue, you stain it, and then you want to do your you want to inject your viscoelastic, and then you want to do your CCC. But look what happens during initiation of the CCC. Whoops, that's your Argentinian flag sign, right? So yeah, so what do? You know, do you continue trying to do performing the CCC, completing the CCC and doing phaco, or are you going to convert? I mentioned earlier that this is actually quite a young patient. I mean, depends on the patient that you have. Yeah, if it's a young patient like this, the nucleus probably not that hard. You can actually try to continue the surgery with just phaco aspiration sometimes. Yeah, so this is what I did. I tried to aspirate some of the cortex out, but it's quite sticky. So what I did was add in more viscoelastic, and then attempt to create a nick. Yep, just at the edge of where the extension happened, so that I can actually use my Utrata to make a so-called to complete the CCC in that sense. Yeah. So, all right, and once I was able to achieve this, then I just use the IA probe and yeah, just aspirate the lens material in its entirety without having to use phaco. So yeah, after removing the lens, it looked as though it's still quite stable. Yeah, even though there's an extension here. So I put in my silicone oil and then injected the single piece lens into the bag without much complication. All right. So it is still possible, yeah, but in selected patients only. Yeah. If you can see where the extension of the CCC stops, then of course that will be even better, right? So you know for sure that you are safe. So let's go into one aspect of the surgery as well, which is the intraocular lens power calculation. This might be a bit tricky because measuring measuring the axial length of eyes filled with silicone oil particularly can be quite challenging because of various reasons. One of them is that we do have to take note that there is a difference of the velocity of your either your sound waves, your immersion scan, or your light waves, your optical biometry, yeah, within the silicone oil, because of the presence of oil, and also sometimes you might get small tiny oil globules within that large oil globule as well. You can get unfocused appearance on the B scan, and you might also get what you call is a shifting retina echoes, especially when there is incomplete field of the silicone oil in the eye. So just to show what one example, this is actually a biometry scan printout of the same patient, same eye, but the only difference is that we take into account that this patient actually had silicone oil in the eye, all right? As compared to if you were to do the scan using your normal standard default setting, which is using a vitreous body as your vitreous, yeah? So you can see that the axial length is quite a big difference there, almost 1 millimeter in difference, and of course resulting in a difference in the lens power calculation. So if you're looking at the target emmetropia, it's almost a difference of 2.3 diopter difference in the lens power selection. So always be careful. If you have oil in the eye, you always have to inform your optometrist, or if you are doing it yourself, change the setting into silicone oil for the vitreous. Sometimes you may actually find it difficult, despite many attempts, to try to get a good axial length reading. So what happens then? You can go around this by doing a few, by following some of these tips. You can actually measure, if you have a patient, with vitreoretinal complication, for example, and you expect, you can actually do the biometry beforehand, before referring to your VR surgeon. So that will actually come in useful later on if the patient is referred back to you and then you need to perform cataract surgery. If the patient has cataract surgery and has silicone oil, maybe you can refer them to the VR surgeon and then get the oil removed. Usually we will perform phaco and also oil remove at the same time, but if the lens is still fairly clear, we can still just remove the silicone oil alone, and then later on, if the patient develops cataract, then you get the biometry done again. That would be the best scenario. If you really can't get that, then you probably have to use the fellow eye. Of course, you have to ask the history of the patient, make sure the patient has good, pre-existingly, if there's a refractive error, the refractive error is about the same in both eyes. And then you can use the fellow eye as your guide to the axial length of the affected eye. Of course, this is provided that the patient's fellow eye is actually in a fairly good condition. There's no thysis bulbi or anything like that. This is a bit radical, a bit invasive as well because of the exposure to radiation, but you can actually use a CT scan image to actually help you measure the axial length. The final option would be to consider the use of standard power IOL if you really have no other options. All right. So some of the surgical strategy for phaco in vitrectomized eye. Yeah, preoperatively, the main issue is the pupillary dilatation. So you might resort to using long-acting cycloplegics like your atropine or homatropine with topical NSAIDs eye drops. It can be started as early as 1 week prior to surgery to help you with your pupillary dilatation. In terms of anesthesia for the surgery, you can use topical or even regional like peribulbar, subtenon, retrobulbar. If you ask me personally, I would prefer the patient to be on the regional like a peribulbar or even subtenon. Yeah, because these cataracts are usually quite hard if they are elderly. There might be pre-existing zonular weakness and of course the small pupil. So all this will give you a warning that you might have to anticipate complications in these eyes. So always be careful. Go for a regional block if possible. Intraoperatively, when you talk about incision, there's not much of a difference actually, but if you go for, if you're planning to insert a single piece or even a 3-piece foldable lens, you can just opt for your regular clear corner incision. But what is important is that you should have a good watertight incision so that it will not cause AC maintenance to be an issue. Yeah? Your AC needs to be as stable as possible, so your wound will definitely affect your AC stability. In terms of your CCC, use all your available devices or stains that you have, because it may be challenging because of poor ray reflex, or maybe there's even anterior capsular fibrosis. So staining with vision blue and also having a sharp needle for your cystotome will definitely help you perform the CCC safely. If you have these extra instruments like your macrorhexis forceps or your long Varner scissors, these will definitely come in handy when you encounter some difficulties in completing your CCC. So intraoperatively, hydrodissection, hydrodissection. I wanted to point out hydrodissection because you may remember the earlier photo I showed you where there is a lens touch with possible capsular breach. So in these patients, you have to treat these eyes as though they are polar cataracts, right? So avoid your hydrodissections in these eyes. In other situations, you should be able to perform your hydrodissection, but just be slow and gentle, and please allow the fluid to come out of the eye, with decompression, so to avoid posterior capsular blowout, right? I have mentioned before that, avoid hydrodissection, especially in the polar cataracts. If you encounter a patient, that develop a white intumescent cataracts very early, after maybe just 1 or 2 weeks after the vitrectomy, then there might be a problem with the integrity of the capsule, right? So avoid hydrodissection in these cases. When it comes to nucleus management or the phaco-dynamics of your machine, there's not much of, I'm not going to go into specifics, but just use whatever techniques that you are comfortable with, that you can perform confidently, so there will be less trauma to the zonules and to to have less complications during the surgery. Although we say phaco chop, direct phaco chop or vertical chop will be the best in a dense cataract, but if you are not confident in performing that, then don't do it. That will actually cause more problems later on. You can do divide and conquer, in these eyes, if you are very comfortable with this technique, right? When it comes to the settings and also your bottle height, keep your bottle height a bit lower than usual, and make sure your irrigation is turned on whenever the phaco IO probe is in the eye, because that will actually, you will notice that the AC will shallow and deepen very rapidly, and every time you have stretching of this iris, patient might get, might winch and you get uncomfortable. That's why I still prefer a peribaba or subtenon injection. So the thing to remember is that the post-vitrectomized eye cataract is as though you are doing a high myop cataract with a polar cataract as well. So this is definitely quite challenging, but if you keep in mind those few things that I mentioned earlier, then it's possible. Don't ever give up. Once you're confident with your usual cataract surgeries, whether soft cataracts, hard cataracts, then you can go into cataracts in this post-vitrectomized eye patients. All right. So I'm going to end my talk with a few videos here. So this is actually a patient with post-vitrectomized eye with oil field, but you look at his pupil. It's really, really small. Probably he had very intense inflammation after surgery, and you have these membranes surrounding the pupil. So that actually limits the pupillary dilatation. So what you can do is actually just gently, of course, inject your viscoelastic and then gently peel off these membranes. Be careful not to breach the anterior capsule when you are doing this. Just gently peel off those membranes, and you will notice that the pupil will, enlarge quite well to a size that you can be comfortable doing your CCC. All right. So once has been peeled, I've stained the capsule just for better visualization, and then with viscoelastic in, you get a very good size pupil, right? So this is another example. This is actually a patient post-vitrectomy with gas still in the eye. Came back within 1 month with redetachment. So there's gas in the eye, and then his cataract is quite significant. I had to remove the cataract before I could proceed with the posterior segment surgery again. So this is the pupil size. As you can see again, pupil is actually quite small with posterior synechiae already. Injected adrenaline, but it didn't help. So what I did was again use my viscoelastic, and this one I didn't have to peel any membranes, but mainly use your spatula to just do synecholysis of the posterior synechia, and then the pupils is is good enough for your CCC and your phaco. All right. So what I want you to notice is here during the you look at how deep the AC has become, and the lens has retropulse posteriorly. So this is actually one thing that you will notice sometimes in this vitrectomized eyes. All right. But when you're doing surgery, you notice that the pupil is getting smaller and smaller again. All right. So that can be a problem sometimes. But yeah, if you keep your phaco probe at the center, avoid going to areas where you can't see, you can still perform the surgery in a very safe manner. All right. Another thing that I would like to point out is later on after the nucleus removal, you will see that the iris will start prolapsing. All right, and something will come into view. I hope I can catch it in time to show you guys. All right, so the probe is out, the iris starts prolapsing, and there. Oh, sorry about that. Let me try to get the. Okay. Yeah, you can actually see the meniscus of the gas bubble. Yeah. Coming into view. All right, so the gas is still behind. So when you have this gas there, you will definitely push the posterior capsule and everything anteriorly. So that's why your AC will become shallow and everything starts prolapsing out. If you have a posterior capsule integrity issue here, the posterior capsule can suddenly give way during this part. So what you can do is actually, before you remove your phaco probe, maybe what you can do is you can stop the irrigation while the phaco probe is still in the eye, and then with your left hand holding on to the viscoelastic, inject viscoelastic into the eye before you remove your phaco probe, just like what you would do in a polar cataract, right? So this will prevent the PC from splitting. All right, so this is actually what I was referring to earlier about doing phaco and also a removal of silicone oil from the anterior segment. All right, in this example, I've edited the video so that the cataract surgery has been completed. What will happen here is that I will be doing a posterior capsulotomy. All right, so inject your, So inject your viscoelastic to flatten the posterior capsule. You can actually see very clearly. So use a needle to breach the posterior capsule. All right. And then your utrata will then be used to create your posterior capsulotomy. It's a bit tricky, yeah. You will see the capsule is folding, and you might not get a clear view. But always go in again and inject some viscoelastic if you need to, just to give you a better visualization of the margins of your posterior capsule, posterior capsulotomy. Sorry. All right. So it's a fairly small one, but it's adequate for removal of the silicone oil. All right, so the posterior capsulotomy has been completed. So you just use your AC maintainer extend your paracentesis and use the AC maintainer into the side port wound. And then this is actually a Payman's cannula, which you may not have in your OT, but you can always substitute this with your Branula. All right, your pink Branula. Just remove the steel needle inside it. Cut the plastic tip shorter so that you can actually use that to aspirate the silicone oil in place of this Payman's cannula. All right, your infusion setting should be your bottle height. Yeah, your infusion should be at least 50 centimeters high. Of course, you can always titrate it based on the stability of the eye. You don't want the eye to be collapsing a lot when you are removing the silicone oil. Okay, so here you can see the oil has been almost fully removed from the eye. So yeah, once it's removed, you can actually inflate the bag. Make sure you are in the bag. That's why I would prefer your size of your anterior CCC and the posterior CCC to be a bit different, so they can actually make out the difference between these two. Yeah. Make sure you are inflating the bag and not the sulcus or in the vitreous. All right. And you can still put in your single piece foldable acrylic lens in these eyes. Yeah, if your bag is stable, your CCC anterior and posterior is round, not too big, yeah, you can actually implant this. If you are not certain of your posterior capsulotomy, whether it's stable enough, or you're not sure that you are actually injecting into the bag, then what you can do is actually replace the single piece lens with a 3-piece lens, and you can put it in the sulcus with optic capture. Yeah, that's perfectly fine as well. So yeah, this is just the final part of removing the viscoelastic. You can actually see the shadow of the posterior capsulotomy here. Yeah, it's just quite a small one, so it's still round and stable. So the lens also seems to be quite stable in the bag. So yeah, that's it. This is something that you can attempt if you would like to try. And I mean, if you're faced with a situation where there's emulsified silicone oil, high IOP, dense cataract, you have to remove it. You have to remove it. Yeah. So the take-home message here is, do try, because if you don't try, you will never know. If you try, you have a complication, at least you gain from the experience. Ask your seniors, how they go about doing it. Because if you don't venture into it, you will gain nothing out of it. If you're decided to try, you make sure you get a thorough history and also a careful examination of the eye, so that you don't bump into any surprises during the surgery itself. Plan your surgery well. The planning starts prior to the surgery, yeah. And get all the instruments that you have in hand in case you have any complications that you anticipate. And always consult your friendly VR colleague for opinion, whether if you can proceed with the cataract and also silicone oil removal in this patient. Yeah, we are more than happy to help you. You help reduce our load as well, right? So okay, so actually this is basically my last slide. CK, can you put up the second poll question? All right, so based on what you have heard so far, my second poll question is actually, would you actually attempt cataract surgery in these eyes after you have heard this talk? Whether it's definitely, maybe, or not at all, okay? But to be fair, actually, it's not that difficult, yeah? If you're confident in your phaco, you have done many, it is possible, yeah? So always give it a try, yeah? No harm, yeah? Stay confident, be confident with yourself, but again, safety of the patient's eye is paramount. If you're not, just refer them out to someone or get your senior colleague to help you perform the surgery. All right. So thank you very much for your attention, and I welcome any questions or suggestions, or your input if you have sharing of experience, be it previous surgery. Yeah. All right. So yeah.
Okay, thank you, Dr. Teh. So you all can answer the second poll questions. Thanks, Dr. Teh. Can you unshare your screen?
Oh yeah, sorry. Okay, sure. Okay.
We will go into the questions. Some questions have already been answered by Dr. Mohan. So we will go through those questions again. When is the ideal time? I mean, the questions can be directed to both Dr. Mohan and Dr. Teh. You guys want to answer the questions, and then you got special opinion also, you can always say that. So when is the ideal time to inject anti-VEGF prior to patient? So what is the purpose of anti-VEGF? Of course, anti-VEGF is to, I didn't mention in Dr. Mohan's slide, to reduce, we try to reduce the post-operative bleeding or intraoperative bleeding, and then it kind of made the outcome favorable. So the Dr. Mohan's already mentioned, answer is about 4 to 7 days prior to surgery. Is it similar, Dr. Teh?
Yeah, I will go in as early as sometimes even because I mean, it depends on your OT schedule and also your injection schedule in your clinic. Of course, you have the freedom of injecting them 3 to 5 days is more than enough. If you don't, then you might go 1 week before. That's fine. But I think never go beyond 1 week, because if there is very broad tractional membranes and more than 1 week later on, you will sometimes encounter those very bad crunch, you know, the VEGF, anti-VEGF crunch, whereby the contraction of the membrane causes even more detachment of the retina. So anything more than 1 week, I do not recommend actually.
Thank you, Dr. Teh. Dr. Mohan, what is your choice of anti-VEGF nowadays prior to vitrectomy?
Well, it doesn't really matter, but ranibizumab is still the most frequently used prior to vitrectomy.
Yeah.
In some cases, they use bevacizumab, but that's like, I think Dr. Heisel had asked, that will go under the off-label use, right? But I have no experience in using, let's say, Eylea for it. Yeah, I think so. Ranibizumab will be the choice.
Okay. So Dr. Ho Hao Chi also asked, do you stop antiplatelet? I think antiplatelet aspirin, he mentioned should be aspirin. So Dr. Mohan said that they don't, usually you don't offer antiplatelet, but warfarins and other blood thinners, so you need to off it, and then you have to convert patient to another antiplatelet, or sorry, and another blood thinner before the operation.
Yeah, I mean, this is something that I've only done, I think, over maybe the last 6 or 7 months. Before this, I used to stop the antiplatelet, but there have been a number of publications, especially coming out of the US, in which it shows that you don't have to stop antiplatelets. It doesn't cause any extra bleeding during surgery, or it doesn't have any adverse post-operative outcome. So I've stopped using it, stopping them from antiplatelets, and I don't find any differences.
What is your opinion, Dr. Teh?
If the patient is on double antiplatelets, then I'm a bit more cautious, because it depends on the gauge of your vitrectomy as well. 23 gauge is actually still all right, but I mean, maybe in the US and all that, they're going more towards 25 or 27 gauge. So the risk of bleeding is probably a bit, I mean, it's lesser and probably able to be managed. But warfarin, definitely, we will admit the patient early, and then we go into for bridging therapy. You know, we convert them to subcutaneous low molecular weight heparin. Yeah. At least we can actually control those bleeders compared to warfarin, which we have no way of stopping the bleed if it happens.
Okay, we go to all others unanswered questions from Dr. Tan Seng Fai. So to Dr. Teh, is the gas-induced cataract reversible? If yes, how long we give before we go in for phaco?
Okay, yeah, thanks Seng Fai for the question. Well, if you talk about gas-induced cataracts, depends on the patient as well. I think in a young patient, sometimes you do see that the gas cataract will either stabilize or even fade off a bit. Initially, immediate post-op, you can actually see quite significant. It looks like either a snowflake or like a Christmas tree-like appearance. But you can wait. Of course, how long do we give before we go in for phaco? It actually depends on the inflammation and also the status of the lens. Not really depending on the gas cataract itself. If you see that lens is becoming very intumescent, the AC is shallowing, the IOP probably is going up, then you are actually a bit worried, yeah, that there might be something else other than just a normal gas cataract. So I mean, a good timeline for a phaco after vitrectomy, I think at least go 6 weeks to 2 months after the vitrectomy, unless you have to go in for an emergency for any urgent reasons, like I mentioned, high IOP, very intumescent lens. Yeah.
Okay. Another question from Dr. Teh from Dr. Chong.
Oh yeah.
So,
okay.
So you can, so I will choose a question about your second video, the one with gas filled with cataract. After 3 ports insertion, will you ensure the gas is completely out before you proceed the cataract surgery?
Okay. Hi, first of all, Chong, William, how's everything in Taiwan? I hope you're doing well. Thanks for the question. Yeah, regarding patient with a post-vitrectomized eye with gas still in situ. That means it's probably within 3 months of the vitrectomy. Of course, if you do see the gas bubble and you are going in for you're going in again for vitrectomy, then usually I will definitely put my pots in first. And if you know that there's a gas bubble in, yeah, of course, get it out from the eye before you proceed with your cataract surgery. That might actually be safer. The issue I had with that patient, which I shared the video, is because the bubble is actually quite small. I couldn't see it anymore. But I knew I had to go in again for surgery. So and it was a redetachment. So I did not want to needlessly irrigate and wait for a gas bubble to come out if there was one, because I couldn't visualize it before the surgery. Yeah.
Okay, Dr. Mohan, from Dr. Chong, about ADD case, what is your criteria not to and do combined phaco PCRI and DPD?
Yeah, I think for this, the most obvious answer to begin with, if your cataract obstructs your view of the posterior segment, then you definitely have to go ahead and do the cataract surgery. Right? If I don't have to, if the view is clear for me to approach the posterior segment, I don't do the cataract surgery. Simply because in diabetic cases, you're trying to limit the amount of inflammation that's in the eye after surgery, so you need to control that. But when it comes to necessity, if it's there's a posterior subcapsular cataract especially, you have to do the cataract surgery first and combine it with vitrectomy. The other indication is if you have advanced diabetic eye disease, which have you find that there's already posterior synechiae, then it might be worth doing a cataract surgery and leave it aphakic to give you a better view of the posterior segment and do the vitrectomy.
Okay, Dr. Mohan, is it always we need to put lens in patient with poor prognosis eye? Let's say the patient has a cataract, and then you did the cataract surgery, and then when you go into the posterior segment, then you look at it, the eye is basically a concave eye. So will you still put in the IOL?
Two schools of thoughts, isn't it, on this? A lot of people, first of all, there is a question of cost. Why do you want to charge a patient for something that is not going to give any additional benefit? But the aim of surgery is always to restore as much of normal anatomy as possible. And that's on the direction that I go with. If I remove a lens, I would rather put in a pair of lens in, right? So it restores as much as the normal anatomy, because leaving the eye aphakic has its own set of problems. So even if it's a poor prognosis eye, we had decided to go in and give the eye a chance. So you putting in the lens is not going to give any additional benefit in terms of let's say giving better vision, but it might benefit in terms of reducing the rate of aphakic glaucoma. It might theoretically reduce the number of the amount of VEGF that is flowing to the anterior segment. So theoretically, there are benefits, right? And I'm a proponent of putting in a lens in.
Okay, thank you, Dr. Mohan. I understand that. So for last question from Dr. Teh, from Dr. Chong as well. So as Dr. Teh mentioned, post-vitrectomized eye behave like high myope with compromised back. So automatically, if you think lower our parameters, lower our bottle height. But Dr. Chong thinks that he more comfortable in doing in the high bottle height setting. What do you think?
Okay, all right. Thanks, Chong. For me, if you increase the bottle height, you might encounter. I mean, the reason why you increase the bottle height, I assume, is to give you probably a well dilated pupils. Sometimes you will see that because of the iris retropulsion. But certainly, if you are comfortable doing surgery with a high bottle height, as long as you get a good size pupil, then by all means go ahead. But I would I mean, that's not the so-called the general consensus. Usually we ask to lower the bottle height is because you know, if your bottle height is too high, you're going to have a very deep AC. You might struggle even to reach the cataract during the surgery, during the phaco. So that could be a problem. So I would rather to have a lower bottle height settings, basically because you don't want an AC that is too deep. You can actually you have many instruments to help you with the pupil, the small pupils. So even using a coagulant to actually push the iris away, you know, what we call the modified Sioni maneuver, that will help actually the propagation of the fluid into the anterior chamber again, because in a very deep pupil, that will actually help you if you have a very deep AC. But yeah, general rule is, I think, a low bottle height. But again, you know, one man's meat is another man's poison, right? So if you're comfortable with a high bottle height, you have no problems going about doing the surgery, you have good outcomes, go ahead, you know.
So my personal experience in high myope patient and post-vitrectomized eyes, and those patients are usually quite young and then post under general anesthesia.
Yeah.
So the eyeball become even more soft.
Correct.
So in this kind of cases, so I tend not to bring down my bottle height too low, but not as my normal cataract surgery bottle height. So because I understand that the bag is sometimes they are quite loose, and then the jaw is already loose and weak, and then it might worsen it also. So things can become quite out of hand later on. And then what I also encounter the iris repulsion syndrome after I put in the phaco probe, and then iris start coming down, then become very, very small. If you're to those young surgeon, or myself also, I consider young surgeon as well. So don't be too anxious. Just stay calm. You have the iris hook. You can always come out and then put iris hook if you're not comfortable. If you don't go sculpting and taking the segment, you go under the iris. We don't have much view. The end of a PC line will be more disaster. Okay. Any more questions from the audience? Well, we have quite a good participant up to 80 plus. We're very happy. Everyone can gain some knowledge from this Zoom webinar. Really more than our expected time is really 4:12. With that, I thank you everyone, and thank you MSO, and thank you Dr. Mohan and Dr. Teh. We will have more of this Zoom webinar from the Young Ophthalmologist Group, from Malaysia Young Ophthalmologist Group in the future, hopefully, and also teaching for master students as well. So thank you, and then have a good weekend. Thank you.
Thank you, everyone. Stay safe. Bye.